So good morning. It's my pleasure to introduce our speaker this morning. It's Dr. Bryan Alsip. Dr. Alsip is Executive Vice President and Chief Medical Officer for University Health System. He went to medical school at Georgetown and then did medicine, preventive health, and public health training, getting a master's from Johns Hopkins. Dr. Alsip's been a great friend and partner to the Department of Surgery, and he's speaking as part of our Introduction to Business class, which we've incorporated into grand rounds on physician and hospital financing. Bryan, welcome.
Thank you. Thank you, Dr. Stewart. It's always a pleasure to talk about such a dry topic on a Monday morning. I'll do my best, though. It's not 200 slides. I'll probably get you out of here a little bit early, which is always appreciated. But, there's a lot of stuff going on in healthcare if you hadn't figured out. So some of this is kind of as it was written, and some will probably change. But I'll try to focus really on the standpoint of what you all might need to know as physicians, rather than sort of a financial expert, and particularly for those of you who are younger than myself and Dr. Stewart, because a lot of this stuff is really going to change. It has already and will continue to do so. So I've looked at some of the topics that y'all have had in grand rounds. You've touched on a few of these things. Personal finance, MACRA, hopefully y'all kind of know at least a little bit about what that is. That's kind of the old term now. It's called the Quality Payment Program, but that'll change again. You learned a little bit about complexity. I'm going to add to that complexity, and then we'll talk today about kind of the money flow, not just to hospitals, but also to you all as physicians, because of course they're different and it's confusing. So here's my disclaimer. I'm a doc. I work with other docs. I work with administrators. I'm not an accountant, budget analyst, economist, officer, or frankly anyone of those above. So really have no desire to be any of those, but I do know enough to be dangerous, and I think it's important, again, for you all to know enough, because like it or not, if you don't know where the money comes from and how it flows and how it affects you as a physician, you'll find yourself a lot of times sort of figuring out things the hard way. So hopefully I'll give you a few pearls of wisdom and a little bit of background about how stuff works. So some of the things to know when you talk about payments to hospitals and physicians is they're different. They're not the same. You'd think they would be, but of course they're not. There's different incentives and there are different motivations behind what actually creates the incentive for getting some of those payments. It's frankly very confusing, so don't expect to understand it all at the end of this. Sadly, it doesn't make sense all the time either. That's just true. But as I said before, I really encourage you to sort of stay on top of this to some degree. It's really important to understand your clinical work more than anything else and be good docs, but you have to know some of this, particularly if you go out in private practice, or even if you don't. The world is changing, even in the world of academic medicine, and we're not in any way, I think, isolated from that fact. So why is this important? There's a lot of money at stake. So if you look at that graph there, I won't focus on the specifics, but that graph, 1.4, 1.6 is in trillions. That's trillions with a T of dollars. That's a lot of money, all right? That's another reason why people are concerned about healthcare costs and why we don't think that the track that we're on currently is really sustainable. So when you look at it we'll start from the hospital perspective. It's a little bit murky. There are charges for everything, and you've probably seen this either for yourselves, your family members, or even in the media. Hospitals might charge $500 for a Tylenol, right? But they get paid different rates. So you might get paid, I don't know, $1 for that Tylenol, and it might have cost you 5 cents. No two payers, whether it's a government payer or a private payer or whomever else, will actually pay the same amount for that Tylenol. And not everybody charges the same. So if you go to 4 different hospitals, health systems here just in San Antonio, they're all going to charge something different. So right there, you're understanding the confusion, right? Charges almost don't really mean anything. There's generally within a given system a standard charge to cost ratio that you can sort of use to figure things out. But just know that it varies system to system and then payer to payer. Government payers tend to negotiate below costs, so you sort of start off losing money for the most part. And the commercial folks kind of negotiate, and they could give you a little bit more, or they could give you a little bit less. It all depends. So just keep in mind that's it's not just like going into a shop and buying something and there's a standard cost for something. It varies tremendously, not only for the service that's being provided or for the device or for the pharmaceutical, but it varies dependently on also who you're working with. So we'll talk about a couple of payers. The granddaddy, of course, that we think about is Medicare, and if you don't know, Medicare sort of started back in 1965. A lot of the work that President Johnson did. Originally, it was to sort of cover the aged. They picked the age of 65 because they didn't think people would live that long. After that, you wouldn't have to worry about paying for health care. Well, we're living longer, and so that's not working out so well, at least in terms of the finances, which I'll show you. But another thing to keep in mind that they expanded it a little bit later in the 70s to cover not just people over 65, but those that were under 65 with certain disabilities, end-stage renal disease, ALS, and so forth. And in fact, in the population that we serve at University Health System, probably about half of our Medicare population falls into that category. So it's, again, it depends on the patient population. It's a little bit dated. I think it's over 50 million beneficiaries now, and it's going to grow. I'll show you a graph that illustrates that. And then below it, you see a little bit of the breakdown. Those, you can see even about 40% are over age 75, and that's also growing because of the aging population. So here's kind of the track and trend of where Medicare is going. That's a lot of people. And so, you know, if we're kind of in the middle there between 2010 and closer to 2020, you can see because of the baby boomer population, it's getting ready to go on a much more steep slope in terms of trajectory. So that can be a challenge because there's only so much money to go around. Here's a pie chart of federal spending. Now this is 2010, but I'll give you one that's a little bit more up to date that shows expenses as well as revenues for the country. But even in this one, you can see about 12% of federal spending was just toward Medicare alone. That's a big chunk. And when you look at that time, defense discretionary spending was about 23%. You'll see that shrunk compared to this, which has actually grown. So if you also look at how Medicare spends its money, it's also changed. So in 1999 versus 2009, a 10-year difference. Majority of it was toward inpatient hospital costs. And some of that's, a big chunk of that came out in Part D, which is really prescription drugs, which we'll talk about in a little bit. And some of it's these other things like DME and skilled nursing facilities and other things that, and managed care, which is another element of the growth of Medicare in terms of how it's being spent, that are shifting where those dollars are going, even within the sort of standby of Medicare. So there's currently 4 parts. Again, this could change. There's a lot of talk about what might happen. Part A is kind of what you think about, and from the hospital perspective, that's what hospitals get paid, and I'll show you how that's funded. Part B is supplemental insurance. There's some skin in the game for people, but that also covers outpatient, as well as some of the physician fees. Part C is the more interesting one. It's managed Medicare, which we'll talk a little bit about, and then Part D is primarily covering prescription drug costs. So if you look at Part A, it covers hospitals, SNFs or skilled nursing facilities, and some home health. It's about 40% or a little bit more of all the Medicare spending right now, so it's a significant chunk. If you haven't looked at your pay stub, assuming you get one, you'll notice you're contributing to this. Unless you're one of those lucky people that somehow could get out of it. I don't know, somehow that works sometimes. But anyway, about 86% or more is coming out of our paychecks to fund this. And there's a little bit of a trust fund. The important thing, if you go back to that graph I showed you where there's a steep slope increase in the number of people who are Medicare beneficiaries, on current spend tracking, we're going to run out of money in 2019. So that's not very far away. About 2 years away, so that's why this is a big deal. Not only is there a lot of money at stake, but we don't have enough money to pay for all that, which is why there's a lot of discussion about how to change Medicare or reform Medicare or right-size Medicare or make it better. We'll talk a little bit about that, but this is one of the things I wanted to share with you because it's not sustainable. You hear that a lot. Well, now you can kind of understand why. The Part B, as I said before, is really to cover a lot of outpatient costs, physician fees, stuff you do at an ASC, lab tests. And there's a little more skin in the game here. You have to sign up, and you actually have to pay a certain premium if you're eligible for Part B. So it's not necessarily a full entitlement, but it really covers sort of the outpatient versus the inpatient. Part C started off as something called Medicare Choice. It is now Managed Medicare. Anybody heard of a company called WellMed? Okay, so WellMed figured this out a long time ago. Dr. George Rapier, a real smart guy, he's a good doc, better businessman, at least in this area, understood this is a really interesting prospect to work where you essentially deal with, I wouldn't say it's not a capitated group, but it is taking a group of cohort of patients that are Medicare, for which there is a funding source, and if you can manage their care, meaning keep them healthy and keep their costs down, well, then you're the beneficiary of that. And the government likes that because it feels like they're not just giving out money. What they're doing is they're giving you money to improve the health of your patients as well as reduce what are considered unnecessary costs. So it's a better model, but it's only one part of that whole Medicare scheme. And then the prescription drug costs, again, this is something that's it's under fire as to whether it will stay or not, but it does help folks pay for particularly high cost drugs. This is where it starts to get really confusing. Essentially, the payments for hospitals from Medicare has gone over through an evolution over the past couple of decades. This prospective payment system is really what's defined how hospitals get paid. It sort of goes back to that charges versus costs and charges versus reimbursement. But it started to roll in more than hospitals. You can see there home health agencies, skilled nursing facilities, rehab, and so forth are now getting paid differently than they used to be. So instead of just getting a certain amount for a certain fee or for a certain service, they're now actually being held accountable based on how things are actually coded, and that's what we'll get to in a little bit. I won't spend too much time on the details here, but the big thing to understand is this MSDRG. That's what sort of was the big change in hospital payments. So it's Medicare severity diagnosis related groups. So essentially what they'll assign is for a specific diagnosis you all write as in the chart, EMR, that gets coded as something. Well, how it gets coded is how it comes up on the back end is what you're going to get reimbursed for. So on the hospital side, that's particularly important, and we don't get really taught in medical school or even residency how to write or document in a certain way that makes the difference. So we write in clinical speak, right? We chart the way we have been taught. That's not necessarily how it works when you have to learn what certain words mean when the coders pick them up. And I'll show you why that's important. So let's look at something, this actually started about, I think it was 2008 was the most recent update to the MSDRGs, but at the bottom there you've got three. So this is for heart failure and I think shock, MSDRG 293, and there's three categories for it. So there's without complications and comorbidities, with complications and comorbidities, or with major complications and comorbidities. And so depending on what you write in the chart and how the coders interpret that, you'll be assigned a different weight. And your amount reimbursed is based on what that weight is. And so the higher the weight, the more reimbursement. So if you've got somebody, at least theoretically, the way Medicare sees it, with higher complexity or greater acuity, you should have a greater weight to that code, which means you should get paid more for taking care of that patient. So you take something as simple, it's not so simple, but as simple as heart failure and shock, and depending on what you write in your chart and how it's diagnosed or how it's interpreted by the coder, it can get put into one of these categories. Or if you're coding yourself, you can put it in one of these three categories. But the idea is that you're going to get paid, at least the hospital is going to get paid on an MSDRG basis at a different amount based on each of these three categories. And that's it. And that's really for an episode of care. It doesn't, that's really your only opportunity to make that change. I'll just touch on this. There are some things that added the confusion. There's something called DISH, or the disproportionate share This is usually to offset losses between what Medicare would pay and folks who are, you take care of who are uninsured or underinsured. There are some adjustments that you get as a hospital that will increase your reimbursements based on certain things. So if you're a teaching hospital, if you're a safety net hospital, so like University Hospital happens to fall in those two categories, they'll get a little extra bump because of this. The problem is, if you read the ACA, and I'm sure you all read however many thousand pages it was when it came out in 2010, this was scheduled to go away. Because the idea was that at least for those that weren't getting some kind of coverage, they would either get it on the exchange or they would get it through Medicaid expansion. Well, that only works if you expand Medicaid, and you kind of figured out by now not every state expanded Medicaid. And so the problem is this is still an issue. So there's a trend to get rid of the dish. There's nothing to replace it in a lot of states, and so there's still that gap in terms of income and coverage. On the outpatient side, again, it's a little more confusing, but it's about the same thing. So these APCs, ambulatory payment classifications, still have certain groups, and they're also assigned a relative weight. So again, I don't want to get into the details, but just understand that weighting is particularly important when it comes to decide how much the hospital is going to get reimbursed for that care that they provide. So this is kind of where the world starts to change. Anybody ever heard of value-based purchasing? Show of hands. Oh, okay, that's scary. Well, it's two things. It's a general term for getting paid for value versus volume, and it's also one of the three Medicare-specific reimbursement programs that hospitals are accountable for. The other two being readmissions reduction, and the other one being the hospital-acquired conditions. So these are based on formulas that include everything from complications that are sometimes claims-based complications, infections, patient satisfaction or patient experience, like they call it now, mortality. And there's a formula that's calculated, and based on how well you do as a hospital compared to your peers across the nation, you're either above a certain line or below a certain line. And if you're above the line, you get extra money. If you're below the line, you get a penalty because it's a zero-sum game. And that's the way value-based purchasing works. Similarly, so for the readmissions reductions program, they focus really on maybe 6 different indicators now. They've started with heart failure, pneumonia, and AMIs, and then they've added a few others like pneumonia, COPD, and others. It's not necessarily a fair program, but it's designed to help hospitals be more accountable to preventing readmissions. So there is, again, sort of this baseline whereby you're compared to your peers. And again, if you do as good or roughly as good within some standard deviation, you don't get a penalty. But if you do poorly, you get a penalty. And so they take that chunk of change that they would normally give you through their Medicaid or Medicare reimbursement, and they reduce that. And the folks that do better, they get your money. So these are all meant to sort of reduce costs and sort of balance things to incentivize people to improve patient experience, reduce complications, reduce infections, reduce unnecessary readmissions. And then the hospital acquired conditions reduction program is a little bit more specific to certain types of infections. And so two that are really important include colon surgeries. Okay, so you all have some influence on that. And Dr. Stewart's actually been one of our champions helping us to sort of figure out ways to reduce our colon surgery infection rates. Because the challenge is that this isn't rocket science. There's a lot of great evidence-based practices and protocols using colon bundles and so forth, preoperatively and postoperatively to reduce those infections. But you have to sort of standardize, and everybody kind of has to do it, because we can get better, but if everybody else is getting better and we're not, then we lose out. Plus, if everybody's getting better, we've got to continue to get better, otherwise that delta remains the same. So all of these three are meant to essentially get hospitals to think about providing better care, reducing costs at the same time, and there are financial penalties for those that don't. So the rest of it is sort of like, these are the visions, right? You're not getting paid for things that shouldn't happen. You're getting paid for things that should happen, and you are getting paid for quality. The most recent evolution are these bundled payments. Okay, so I'll talk a little bit about those toward the end. This is kind of scary too. Bundling is sort of, instead of, again, getting away from the fee-for-service where you're paid for a particular service, is to take a particular episode of care, let's say it's a knee replacement, and you're going to get a certain fixed amount of money. And when I say you, that's not just you, the surgeon, that's you, the surgeon, the hospital, the primary care provider, the anesthesiologist, the post-acute care provider, nobody else gets one single chunk of change, and you get to divide it over the course of the care of that patient. And depending on how well that patient does is how well and how much you get paid. So the first one that came out, the Bundled Payment Care Initiative, was one that was voluntary. I think the only one in our area that has done this is Baptist. Again, it's designed to sort of reduce costs and improve care. They've been sort of moderately successful. I would say the most recent one that came out in July of last year is the Clinical Comprehensive Joint Replacement Program, the CCJR. That is mandatory. It's not here in San Antonio. For some reason, we dodged the bullet, maybe because we had at least one demonstration project underway. But for about 74 cities in the country, if you want to get paid for a knee replacement or a joint replacement using Medicare dollars, you've got to be part of one of these arrangements. So that's a scary proposition because you've got to figure out how to work as a physician with a hospital, a post-acute care facility, and whoever else gets part of those dollars. So we'll talk a little bit about Medicaid, and then I'll go back to some of the value-based stuff. Medicaid, it's another entitlement. It really was designed to help low-income recipients. It's a state and federal program, so the state puts up some dollars and there's a federal match to that. It's considered an entitlement program because anybody who meets the eligibility has to be served, and I'll show you how that's broken down. So you've generally fallen into one of these categories for mostly Medicaid in most states. Pregnant women and children, families with dependents. If you're 65 and older, but you have to be dirt poor to qualify, and if you're blind or disabled. It generally, at least under the ACA, was designed to cover anybody below the 133% of the federal poverty level. Well, that's fine if you expanded Medicaid in your state. If you didn't, there's still a gap. Okay, and so here in Texas, there's still a gap of coverage. You can get Medicaid, and I don't remember at the top of my head, but you basically have to earn like $4,000 with a family of four. It's ridiculous. So there is the Children's Health Insurance Program was sort of coupled to this, again, with a focus on children as well as low-income families. So folks are eligible, pregnant women are eligible, and they have it for a period of time. But again, it's temporary unless your state actually has expanded it. So there's two examples. One is a mandatory. So if you qualify into one of these categories, and there's certain optional ones that you might receive Medicaid funds for, depending primarily on the state and their approach. Hospital payments are similar to what I said before. The only other addition I'll share here is what's called critical access hospitals, which are generally rural hospitals. They get a little bit of an additional bump. They also can do these, what they call these swing beds, where they can use an acute bed or a post-acute bed, depending on their need, because they don't have a lot of resources. They tend to be very remote. Excuse me. So the fee structure for Medicaid in these rural areas is a little bit different, but for the most part, it's about the same. So you got Medicare, you got Medicaid. Let's talk about employers. A lot of people for the longest time have gotten their insurance or their health insurance through employers. Anybody know how that ever started? Why did employers start paying for health coverage? Anybody know? World War II, yeah, what happened in World War II?
They limited the amount of salary you could give.
Right.
They didn't want competition for the industry, so they gave health benefits in lieu of salary.
Right. Who was the first to do that? Company called Kaiser. Right? Anybody heard of Kaiser? Okay, so they're the ones that started. It's exactly right. So the point is that they froze wages during World War II, and they said, well, we got to do something to incentivize employees, so we'll give them health insurance. And so it sort of set a precedent. In fact, if you go back to '64, when General Motors, believe it or not, was the largest employer in this country, they covered employees, families, retirees, cousins, uncles, dogs, cats. I mean, it was pretty much everything, right? You go ahead a couple of years, maybe another decade, AT&T was actually the world's largest, or this country's largest employer, and similarly so. You know, it was a good package. But what these folks didn't calculate, in fact, General Motors didn't, is again, things like Medicare. They didn't count that these folks would live for a long period of time, and those costs would rise extensively over long periods of time. And so you look at it now, today's largest employer, at least in the country, it looks a very different scenario. In fact, 1/3 of all Walmart folks as employees are on Medicaid. Another third have absolutely no coverage whatsoever, and another third have plans, but they're generally high deductible. So folks who are, you might get access to care, you might have an insurance program, you might have coverage, but you might have a $10,000 deductible or a $5,000 deductible. So the thing I want you to take away from this is that that's going to continue to shift. Even if you have insurance, you may not have noticed it now, but more and more of that is being shifted toward the individual or their family and away from the company itself simply because of the rising costs. So keep in mind, we're #1 in Texas. Okay, we're something to be proud of? Not really. We are #1 in the uninsured rate. This figure 24.81 is actually from 2015. So this is well post ACA. Sadly, we still are the state with the highest rate or percentage of folks without health insurance. So that's a challenge. We also have the largest number of children in terms of frequencies without health insurance. And people don't think about it, maybe they don't consider it this way, but most of the uninsured folks are in the working age population. They're between ages of 18 and 65. And so we're working in a state that's not particularly well funded for health care. We don't have a lot of coverage, and we have a lot of uninsured folks. Now, that is varied. If you look at the state map, which I don't have as a heat map, Bexar County has actually improved. You know, I think we went from about 24 to 26 down to about 18 to 20. But if you go down to the valley, particularly down in the Rio Grande Valley or even along some of the border states, if I showed you a heat map here, some of those counties along the border still run in the 30 to 40% range of uninsured. So it's very disproportionate, and you know, as big as a state as we are, Texas is, it's a big state. We have 254 counties. It's a very rural state, even though we have 3 of the largest cities in the top 10. And so it makes it very much of a challenge because by the Constitution, healthcare is a county responsibility. And that may be somewhat doable in, you know, areas like San Antonio, Houston, Dallas, and so El Paso, but everywhere in between, it's very difficult because there aren't the resources and there aren't those hospitals to provide those services. So here's a shameless plug for CareLink, only because I think it is somewhat a good program that helps address a few of these things. It's not an insurance program, but it is a payment program. So depending on your eligibility, it was designed several years ago to sort of address that coverage gap where you couldn't qualify for one of the federal programs or you couldn't afford insurance. So up to a certain 300% of the federal poverty level, you can qualify for CareLink. And what it does is there's no copays for primary care. There's a small one for acute care, like an Express Med clinic. There's really a minor payment, but there's no deductible. So it's kind of a lot better than insurance. In fact, what happened when we had about at our peak of CareLinks before the ACA and all the court challenges were finished, we had over 55,000 on CareLink in Bexar County. Now we have about half of that, 25,000, because many of those folks were eligible for the exchange product and they were able to qualify for insurance. Some of them wanted to come back to CareLink because they recognized that wasn't always the same, because with CareLink at least you can get assigned to a primary care physician and get access to a lot of specialty services. And so this is just a quote from the Texas Tribune. There are other models, and in fact I'll talk a little bit later about some of the future appointees of the new administration, one of whom might have some, at least a better knowledge of a program like this. So how is it spread out in Texas? It's still mostly employer coverage. Again, this is going to continue to shrink as the shift or the burden of the costs of insurance go more onto the individual from the employers themselves. So why should you all care? Well, hospitals aren't going away, at least not in the near future. They're going to change. We've become more acute or more aligned to taking care of sicker and sicker patients, but they still drive a lot of the cash flow for how funding works in this country. We need them to attract good talent, whether it's physicians or nurses. We need to provide the care for our folks who don't have insurance or are underinsured. And it has a lot to do with the infrastructure and the economy of a particular community, and certainly in our industry. There was a recent, there's usually an annual program that's developed by Trinity University about the economic impact of healthcare in our community, and it's in the multiple billions of dollars here in San Antonio, and it's still the largest industry for our community. So if you don't have hospitals, you don't have physicians. If you don't have hospitals, you don't have economic growth. So this is why this becomes critical, because it's affecting all hospitals. And this is a little bit what we'll talk about in the future. So so that's all the hospital-based side. Let's talk about more the physician-based side. The growth there is also pretty unsustainable. Again, this is trillions with a T. Think about that. It's a lot of zeros, and it's going way too high. I'll show you a couple different versions of this type of chart, but the goal that people who have looked at sort of ways to control these costs and improve the care for our patients is to sort of focus more away from, again, delivery of fee-for-service and focus more on quality and outcomes. But that's not easy, right? So there's different ways to do it. You can start with fee-for-service down here, and the sort of bundling effect that I showed you before sort of goes all the way up to true capitation, which is a very draconian way of doing things, but there's a sort of a spectrum in between. You can start with these small-based MD practices all the way up to an integrated healthcare delivery system, which could be a large academic medical center, it could be a multi-hospital system, and everything in between. It's getting harder and harder to do business down here. And if you retained anything from your MACRA presentation or the quality payment program, you'll recognize that a lot of the requirements of those programs, whether it's for doing quality improvement work or what they used to call meaningful use, or information relative to sending information through an electronic medium, or the quality indicators and outcomes that you have to achieve, and the revenue that you have to control, a lot of smaller practices don't have the resources to collect all those data and actually send them, much less figure it out. They did actually, in the last version, because of some feedback, say that you had to have a certain threshold of Medicare patients, a certain number that you had to take care of, or a certain amount of revenue. Otherwise, MACRA didn't apply to you, which is actually, I think, was helpful to a lot of smaller practices and smaller physician groups. But again, with all of these things that I'll share with you that make it more and more complex, you can see why, whether it's appealing or not, it's very practical for a lot more physicians to consider some kind of employment proposition than to sort of do independent practice. So what does it look like? Kind of looks like this. Looks kind of fun, actually, but it's a little scary too, right? So if you look at cost per patient, there's different ways to sort of share this. Sometimes it's in a pyramid when they look at what they call high utilizers. You know, you always hear sort of the top whatever percent account for the X percentage of the cost. Well, the top 1% in healthcare expenditures per person account for, you know, the majority of costs. And so these are your sickest of the sick, and it sort of goes down here. These are the folks who are well and don't cost a lot of money. So how do you sort of address this? It's very challenging. So this is kind of a more up-to-date revenue statement for the country here. And so if you look at revenues and expenses, if I were to draw sort of a line around these three pockets to include Social Security, Medicare, and these other entitlements, these are all in the entitlement bucket. So 60% fall into that category. And then you've got stuff like, defense, non-defense spending, and then a little bit of interest over here. So this is a huge problem, and as I showed you in those graphs and those curves that are just skyrocketing up on a very steep slope, these aren't sustainable. So what do? Do you, how do you reduce these costs? Do you hack out Social Security? Well, that's not real popular, right? Do you hack out Medicare? Well, that's not real popular either, right? Senior citizens are very vocal, and they vote, and they don't want you taking any of that stuff away. So it's a real tough challenge. But again, this is one of those things that we're going to have to figure out how to address, because we're going to run out of money, as I shared with you. So this is how we pay for health care. That was a great example. In fact, you want to put it in a different way. This is how you get paid. So if you really want to understand where all the money comes from, just memorize this slide and you'll be good to go, and you can understand everything there is to know. A little bit's changed. This SGR thing has kind of gone away with MACRA. The quality payment program actually eliminated the sustainable growth rate. It was just something that was kicking the can down the road every year with Congress, so that was a nice thing. But most of this other stuff is about the same. And so whether it's RVUs or whether it's the weighting that I talked about earlier in terms of how coding is reflection of documentation, or some of these other things that I'll allude to here, which are adjustments based on quality, whether you use electronic means to share data, how well you're doing on particular revenue reductions or cost reductions is actually what ends up with how much dollars you bring home every day. So this is probably the most simple and probably the best one. So, you know, the good old fee-for-service world, and then there's capitation. We're kind of, you know, here. Any radiologists in the room? Okay, this is the radiologist move, right? Something's going on in here, right? So, sorry, Dr. Otto, appreciate that. So we've moved along this spectrum, right? We're doing a lot of this stuff here on the hospital side. It's starting to affect on the physician side, physician quality. PQRS is now kind of rolling up into MACRA, at least for Medicare. If you're in a managed Medicare program, like WellMed or another program, you get paid, again, not just on the services you provide, but how well those patients are doing in terms of quality outcomes and your cost reductions. So you can get bonuses or you can get penalties for those. And then we'll talk a little bit about this episode-based payment, which is the bundling, which I think to me is really, really confusing and really, really hard to do well. There's still speculation as to how far down we're going to go. So it's sort of an alphabet soup of all of these things. There's the Medicare Shared Savings Program. ACOs are kind of near the capitation, but they're not quite there. It's a really, there's a legal designation for an ACO, and there's sort of a general designation for an ACO. I won't spend a lot of time on that, but again, that's making a system more accountable for the care of their patients. So think of it that way, whether it's cost or whether it's quality. I talked about the value-based purchasing programs. We talked about MACRA, so let's talk a little bit about these episode-based payments. When they were designed, the goal was to say, let's not just look at the patient at a point prevalence period of time, let's look at them across a spectrum of care. So if I'm going to replace a knee or if I'm going to do something, I need to sort of really be concerned with how well they're doing before that surgery and how well they're doing after that surgery for a certain period of time. And then your payment should be tied to that, because you're accountable for that. Not just you, but other folks along the way in the care pathway. So when they were designed, the things that might fit the characterization for an episode basement were the parameters that CMS originally used. It was a high-cost event, right? So they're going to go for stuff that cost a lot of money rather than stuff that didn't cost a lot of money. Subject to wide variation treatment, right? So there's 1,000 ways to replace a knee. If you can get it down to 3, you could probably reduce costs because you're probably going to be doing it in a more standardized way. Services that maybe weren't adequately reimbursed, so things that were needed or necessary for the care of the patient, but there wasn't actually good money for it. Case management or outside the office setting or outside the inpatient setting. This is a little bit debatable. It has a clear beginning and end point, but that's what the episode is supposed to mean. And there should be some CPGs that it's based on. So you can look at it a lot of different ways. The ones that really are mostly in action right now or that are reality right now are these sort of outpatient procedural ones. So we talked about knee replacements and replacements and so forth. You can envision as a surgeon a beginning and an end and some sort of bracketing around that sort of pre-op and post-op in terms of how you would manage that care. As you go up this table in terms of the spectrum, it gets a little bit harder for me. In fact, one of my fears was always that CMS would come and say, well, guess what? Now in the San Antonio market, everybody who's got Medicare patients with diabetes are going to have a bundle arrangement. Well, that's a really challenging proposition, to say the least. But these are not tables that are in just somebody's mind. These are things that have been published as to targets that should be considered for bundled payment episodes of care. And so you can see the transition time is not just during the procedure or during the point of care, but you're also talking about these, oh, wait, this pointer's not working, these look-back periods. So you're accountable for the care of that patient, meaning you get paid along with everybody else depending on how well that patient does a month before they get their bariatric surgery to 6 months afterwards, not just when you provided the service. So that's a long time to be accountable for the care of a patient, but that's the design for these bundled payments. So if you sort of look at it now, this is a little bit confusing, but break up sort of the spectrum of care for these patients. So pre-admission, hospitalization, post-acute care, and then if they are readmitted, hopefully not, or at least unnecessarily so, there's certain accountabilities and there's certain payments. So for hospitals, the surgeons get paid, usually it's most of these episodes, hospitals usually get paid here. Before the readmission reduction program, there was no penalty for this. This is something that the hospitals had to address. And then there's a lot of this post-acute care stuff, things that may or may not get paid for, or at least part of the care episode for that patient. Well, one way to do it is to say, all right, let's put the hospitals on the hook. And so that's where the readmission reduction program came in. They said, okay, you'll get paid, but you're also going to get paid or penalized depending on how well you manage the patient during a readmission. And they picked 30 days for that readmission. So the idea is that the patient, if they received a service, shouldn't get readmitted within 30 days after that service. Does anybody know why they picked 30 days? It's like kind of a good round number. There's not really any science behind it. There's a lot of journal articles that have been written. There's a lot of evidence, but it's kind of like, well, if you get something, you probably shouldn't have to come back with the hospital within a month or so. They got to pick something, so they picked 30 days. So in my mind, I'm actually not any happier personally if one of our patients gets admitted at 31 days versus 29 days. Our CFO might disagree with me, but nevertheless, to me, that's still a failure because it's still an unnecessary readmission. But that's where they sort of drew the line, and that's where they said 30 days, and that's where they said, okay, you can't, if you've got somebody that's readmitted, somebody's going to have to pay for that. So that's one way of looking at it. The other is, well, let's make sure that all inpatient services are now covered. So now what we're saying is not only are the hospitals accountable, but also the surgeons and the primary care providers. So now this is one version of a bundle so that, let's say, if someone's going to come in and get a knee replacement, all of these folks, let's skip the middle part here, for readmissions and for hospitalizations are going to get paid one particular amount of money, and you're going to have to share those. And then if you get a patient who's readmitted within that 30-day period, all of these folks are going to get some penalty. And it could be what they call prospective, or it could be retrospective. So it could happen at the time of readmission, or it could happen afterwards when they reconcile the bills and they say, okay, we're going to take some money back. And then, of course, the doomsday scenario is everybody's on the hook. So this is a true bundle for an episode of care, which means if it's a Medicare patient, they're going to give a single chunk of change for an episode of care for, let's say, joint replacement. And everyone here is on the hook. LTC is a little bit out. That's just sort of an outlier right now. But everyone here is on the hook for how that patient does, which means if they get readmitted, we all get dinged. If they actually do well and the costs are reduced and the patient's outcomes are really good, we might get additional bonus. But in theory, this sounds good. And it makes a lot of sense because we all should be working together on the same team. But as I showed you how that payment structure works, not just for a physician, but also for hospitals, tying all this together requires a lot of work. So I'll give you an anecdotal story. We started looking at bundles at the health system and trying to figure out how could we get ahead of the curve, because we were fortunate that we dodged the CCJR initiative or mandate, but we said, well, that could change. And so what would we bundle? So we hired a group to kind of work with us to sort of work with the School of Medicine and an outside consultant, say, well, let's look at our volumes. Let's look at what we do well. Let's look at where our quality outcomes are actually very good compared to national benchmarks. Let's look at where we have some efficiencies. And we came up with 3 or 4 areas where we thought we might do well. And then we took a couple of field trips, one of which was up to THR, Texas Health Resources, a really great organization. It was, how should I say, it was interesting. They were very transparent with us. We had a great session. We probably spent about 6 hours with them on a given day. And they brought everybody, minus the CEO, to come talk to us about the lessons they learned about setting up their bundle arrangements, what they spent in terms of pulling it together, what their team looked like in terms of building an infrastructure to manage it, what the data requirements were to actually measure the progress, and then what it took to kind of work with payers or employers, which are often some of the partners with whom you might go to for a bundled package. I think it was somewhat cathartic for them because they seemed to want to share this experience. They had been working on this for 3 years, but what was a little bit disappointing, I would say a lot disappointing, was after 3 years of work and several $1 million, I'm not allowed to give you the full amount, they had not a single contract. And so that was, I think, eye-opening because they're not a small entity. They didn't put minimal resources into this. We also went to the Cleveland Clinic. They have a different approach. They have some contracts with their bundled products, but they're not necessarily local. A lot of the ones they have are with institutions, employers primarily, and they're in other parts of the country. So how practical that is for